Hello, everybody, and a really warm welcome to Ask the Experts Maintenance Treatment. We're so pleased to see so many of you here today. So I'm Lizzie Hussain. I'm Deputy Director of Services at Target Ovarian Cancer, and today I'm thrilled to welcome Dr. Rowan Miller. So Rowan is Consultant Medical Oncologist at University College London and St Bartholomew's Hospitals, and she'll be delivering the session and answering your questions today. This is looking to be a really great session. We'll be hearing from Dr. Miller about the types of maintenance treatments available, how decisions are made about which treatment you or your loved ones might receive. And following that, this is your chance to have your questions answered by Rowan in our live question and answer session. I do have to give you a few disclaimers before we get going. So anything that comes out of this session isn't medical advice. It's not a substitute for the information and advice that you've been given by your own clinical team. And we're not able to give answers to very specific individual situations today. So the idea of this session is that it can kind of give you a guide or an overview, and you can then take that back to have any conversations that you want to have with your healthcare team. If anything comes up today that you aren't sure about what it means for you or your loved one, or if you have any other questions or concerns, then you can always call or email our support line to get more information. So I'll see you after Rowan's presentation, and Rowan, it's over to you.
Hi, thanks very much. I hope you can see my slides okay. Thank you very much for inviting me to speak to you today. I'm a medical oncologist. I work in London across two big trusts, UCL and Barts Hospital, which are very different in the nature. UCL, this is a picture on the bottom left, that's the most polluted road in London, the Euston Road, and then Barts, we've got this lovely old quad, and we got visited by the King for our 900th anniversary. So quite different hospitals, but very much looking after the same patients. And I specialise in gynae oncology, but predominantly look after patients with ovary cancer. So today I'm going to be talking about maintenance treatment for ovary cancer, and three main things. Firstly, and the majority of the talk will be looking at first-line maintenance therapy, because that's where there's been a huge number of advances in the last few years. And we'll talk about what BRCA and HRD testing is and why that's important when choosing the best maintenance options for everyone. And also look about the different options and think, if there's a choice of more than one, how do we best choose what's suited for each individual patient? I'll touch on maintenance therapy and some of the rarer subtypes of ovary cancer, and then look to the future about what's on the horizon for maintenance therapy and what might be coming in the future. And then we'll have plenty of time for questions. So as Lizzie said, please do submit your questions. So starting off with first-line maintenance treatment. And this pie chart here just shows you the breakdown of the different types of most common types of ovary cancer. So here you can see this big yellow component is serous, and most of these are high-grade serous. And this is by far the most common type of ovarian cancer that we look after, particularly for more advanced stage disease. So stage 3 or 4 cancers, the majority of these will be high-grade serous. And then there are a number of other rarer subtypes which are also included. They're more common in earlier stage disease, but it's worth noting that most of the trials looking at first-line maintenance treatment were based on patients with high-grade serous cancer. And just taking a step back, until a couple of years ago, if you had ovary cancer stage 3 or 4, that means ovarian cancer that's outside the pelvis, most people were treated in one of two ways. Either they had an upfront operation followed by chemotherapy and then went on to follow up, or perhaps had upfront chemotherapy, then an operation after 3 or sometimes after 6 cycles of chemotherapy, and then went on to follow up. And then there'll be some patients who didn't have an operation, were just treated with chemotherapy. But at the end of chemotherapy, we didn't really have any options for maintenance treatment. Some of you may have heard of a drug called bevacizumab, which is also known as Avastin. And until recently, we only really had that available, certainly in NHS England, for people who had slightly higher risk disease. So for someone who's not had an operation, if there was residual disease left after the operation, or for stage 4 disease. However, in the current era, in 2024, that this is not an option to just go into straightforward follow-up after chemotherapy. So everybody with stage 3 or 4 high-grade ovarian cancer is likely to be offered some form of maintenance therapy. And what do I mean when I say maintenance therapy? Well, it's ongoing treatment of cancer with a medication after the cancer has been shown to respond to first-line treatment. So in this case, chemotherapy and surgery. So for patients where there's no evidence of cancer, and they're in remission, we're trying to prevent the cancer coming back, or if there's had a response to treatment but there's still some cancer there, we want to delay the growth and control the cancer for as long as possible. And lots of different maintenance therapies for ovary cancer exist, and these include what we call targeted therapy, so not chemotherapy, but drugs that target a specific weakness in the cancer. So we're talking about PARP inhibitors here, or bevacizumab, or sometimes we look at hormonal therapy, particularly a drug called letrozole, which is more for the low-grade cancers. And then we have done trials looking at immunotherapy as maintenance treatment, but as yet that's not ready for prime time. It's not yet been licensed, but watch this space. So like I said, for anyone with high grade stage 3 or 4 cancer, we're likely to offer some form of maintenance treatment after chemotherapy, with or without surgery. And what maintenance options do we have? Well, we've still got the option of bevacizumab or Avastin on its own for the slightly higher risk cancers, but we've also got olaparib, niraparib, the combination of olaparib and bevacizumab, and then very recently rucaparib, which is another PARP inhibitor, has just got a European license in this setting. It's not yet available on the NHS, but it's going through the process, and that's another PARP inhibitor very similar to olaparib and niraparib. And I just show you this slide. It's a lot of detail, but the actual detail is not important. It's just really the timeline. So this is to say that paclitaxel was approved for ovary cancer in the early 1990s, and there was another 20 years before anything else was approved in the first-line setting, and that was over a decade ago, where bevacizumab was first shown to be effective. And then it was another 6 or 7 years till we had all these positive trials here looking at PARP inhibitors. And then along the bottom, we've got the regulatory approvals. But that's just to highlight that until recently, there hadn't been much action in ovary cancer, but in the last 3 to 4 years, there's been this explosion of really positive data allowing new treatment options for our patients. So like I said, first-line maintenance therapy for high-grade ovary cancer. So we've got PARP inhibitors, bevacizumab, or the combination. So PARP inhibitors, these are tablets or capsules. They're what we call targeted therapy, and they inhibit a protein called the PARP protein. That stands for poly-ADP ribose polymerase. And they're nearly always used as maintenance therapy. So like I said, given after chemotherapy to maintain the benefit we've got with chemotherapy. And there are 3 PARP inhibitors licensed for use in ovarian cancer. So olaparib, which is also called Lynparza, niraparib, which has got the brand name Zejula, and rucaparib, which is called Rubraca. Currently, as I said, rucaparib is only available in the recurrent setting. And bevacizumab, well, what's that? This is an antibody treatment. It's given intravenously, so it's given in a drip in the vein. It's given IV every 3 weeks. It's a targeted therapy, but it works in a different way, inhibits new blood vessel formation. So if you think of this cartoon here, this lump is a small cancer. And in order for cancer cells to get beyond 1 or 2 cells, they need to develop their own blood supply to provide nutrients. And to do that, they secrete something called VEGF. So they put this, it's almost like a hormone or a growth factor, into the circulation, and it makes the blood vessels grow towards the cancer. And how bevacizumab or Avastin works is that it blocks the VEGF. So it stops that being secreted or attack or hitting the blood vessels. So what you get is this reduction in blood vessel formation, and ultimately the Avastin or bevacizumab works by starving the cancer cells, so inhibiting blood vessel formation and starving them of the oxygen and the nutrients that they require. And I should say, sorry, I apologize, I use the word Avastin and bevacizumab interchangeably. It's the same drug, one's the brand name. So how do we decide what first-line maintenance treatment we use in ovary cancer following chemotherapy? And it's really based on biomarkers. And a biomarker is something that's present either in cancer or in the patient that predicts a response to a particular treatment. And the ones we look at in this setting is something called the BRCA gene and something called homologous recombination deficiency, or also known as HRD. And that's something that we test for in the tumor. So I'm sure many of you will be familiar or heard of BRCA1 and BRCA2, and this is a gene that is often abnormal in ovary cancer. So when any gene is abnormal, we say it's mutated. That's the terminology. And there are 2 different types of BRCA gene mutation. It can either be germline, so that means it's inherited, so it's come from one or either parent. It's present in every blood cell every cell in the body. So it can be detected with a blood test. And it will be detectable in the cancer as well. And it's present in about 12 to 15% of patients. And if you have an inherited or a germline BRCA mutation, that has implications for family members and also risk of other cancers, particularly breast cancer. And it also explains why you got the ovarian cancer in the first place. In a smaller number of patients, we have what's called a somatic mutation. That means that the BRCA mutation has occurred in the cancer as the cancer's developed. So as normal cells become cancerous, they develop lots of different abnormalities or mutations in different genes. And in a percentage of patients, they'll also have a mutation or an abnormality in the BRCA gene. That's about 5 to 7% of patients. So that has the same implications for treatment, but it doesn't have the implications for other family members and other cancer risks. So that's only detected in the cancer. So overall, about 20 to 25% of all high-grade ovarian cancers will have a BRCA1 or a BRCA2 abnormality or mutation. And why is BRCA important to cells? Well, you'll have to forgive me for taking you back to basic biology, but I'll try and explain this as best as possible. So all our genetic information is present in the DNA, and a certain amount of DNA will make up a gene. And the DNA, as you can see here, is this kind of double-stranded helix, and it's the building blocks of life. So all cells are made of DNA. And if you think of it like a ladder with two arms and then the bars in between. So our DNA is constantly under damage and repair, and that's perfectly normal part of everyday cell division and growth and cell replacement. And DNA damage can happen from either something outside the cell. So, for example, radiation, UV, chemicals, viral infections can cause damage to DNA. But more commonly, it's something within the cell. So as our normal cells grow and divide, they acquire damage just through the stress of growing, through waste products produced in the cell, etc. And the damage to DNA can be either to one of the arms or legs, or both of them. And if it's a single strand break, it's, as you see here, it's a bit easier to repair because you've got this other arm to copy from. But if the cell doesn't fix the single strand break, when the cell then divides to grow, this becomes a double strand break. And these are a bit harder to repair, but over evolution, cells have become very clever at repairing their DNA through two main ways: homologous recombination and non-homologous end joining. And what we're interested in ovary cancer is homologous recombination. So when we talk about homologous recombination deficiency, or HRD, this is what we're talking about. And we've known for ages that this is important for ovary cancer because BRCA1 and BRCA2 control homologous recombination amongst other proteins. So if you have a BRCA abnormality in the cancer cells, they can't repair their double-strand DNA breaks very well. It doesn't really matter under normal circumstances because you've got all these other types of ways to repair their DNA. But why this is relevant for PARP inhibitors is that single-strand DNA repair is controlled by PARP. So if you put a PARP inhibitor on a cell, any cell, even a normal cell without a BRCA mutation, you get this accumulation of DNA damage. And in a normal cell, that's okay because they can fix it with homologous recombination. But in a cancer cell that has a BRCA abnormality or indeed is HR deficient, it can't properly fix the DNA damage, and you get this massive buildup of DNA damage, which ultimately causes cancer cell death. So this is why, I mean, PARP inhibitors were originally designed to target BRCA cells, and this is why PARP inhibitors work so well for BRCA and HRD cancers. So to put this a bit simpler, in science, we call this a concept of synthetic lethality. So in a normal cell, the BRCA's intact and they've not got a PARP inhibitor, the cell survives. If you've got a cell with a BRCA abnormality, but no PARP inhibitor, as in the second line, you still get the cell survived. And if you put a PARP inhibitor, you inhibit PARP in a normal cell, you get cell survival. It's only when you knock out both at the one time that the cancer cells die. And someone once explained this, I think it's quite a good way of thinking about it. If you think about a table with 4 legs, if one of the legs falls off, the table still, it still stands. It's a wee bit wobbly, but it still stands. But if you lose 2 legs, then the table falls over. So that's what it's like in the cancer cell. If you lose the BRCA or you lose the PARP, the cells can survive. But if you lose them both, the cell just can't survive. So, and this is what we call synthetic lethality. And as I said, this was the background behind PARP inhibitors being designed for BRCA cancers. But it's not only BRCA cancers that are sensitive to PARP inhibitors. So this pie chart shows all the different types of mutations or abnormalities in all ovary cancers. And you can see here that there's a proportion, like I said, about 20% that have a BRCA abnormality, but there's this other big chunk of the pie chart, another 20 to 30% that have a mutation or abnormality in another gene that does the same thing as BRCA. So these are not inherited mutations, these are mutations in the tumor, but they cause this thing called HR deficiency. So it's an impairment in that type of DNA repair, and therefore sensitivity to PARP inhibitors. And how do we test for HRD? So some of you may be familiar with HRD testing, which is now done for all patients with a diagnosis of stage 3 or 4 ovary cancer. So looking for the cause of HRD is a bit like looking for the proverbial needle in a haystack, because if you think about each one of these wee blue circles as representing a different patient with ovary cancer, we know that it's worth testing for BRCA because that's present in about 1 in 5 or about 20%. But all the other abnormalities that can cause HRD, the same consequence as a BRCA mutation, are present at a very low frequency, sometimes less than 1 in 100 or 1 in 1,000 patients. So it doesn't make sense to test for all these genes individually in each patient. So what we do is we look for the consequence of having HRD. So because these cancers can't repair their DNA very well, they have these scars across the DNA, across the genome that you can see. So they don't look entirely normal, and you can look for that in chromosomes. So if you think of this as a normal chromosome with each different color of gray representing a different gene or group of genes, what you see in HRD cancers is you get these wonky chromosomes whereby you maybe get duplication of one gene, or you get a bit removed, or you get ones jumping from one leg to the other or switching round. So you get this classical mess up of the chromosomes, which you can measure and therefore determine whether a cancer is HRD or not. And like I said, routinely now for the past few years, we've been testing for HRD, or sometimes it's called genomic instability score. So it's a test which tells whether the cancer is HRD positive or not. And these tests are widely available, and they're available on the NHS, and they're looking for this scarring pattern. And it tells you if the cancer is HRD regardless of the cause. And why it's important is that the treatment of newly diagnosed ovary cancer is dependent not just on the BRCA result, but also on the HRD status. And what we offer, or what's available for maintenance treatment, depends on whether the cancer is BRCA positive or negative and HRD positive or negative. So I'm going to go back to some of the trial data that underpins the treatments that we have. And the first one was in 2018. This was the SOLO-1 trial, and this looked at olaparib after chemotherapy. So this was a randomized, placebo-controlled trial in patients with newly diagnosed stage 3 or 4 ovary cancer who had had chemotherapy and surgery, but it only included ladies with a BRCA mutation, whether it be tumor or inherited. So there were 391 patients included, and like I said, they had to have had 6 cycles of chemotherapy and an attempt at surgery where it was possible, and they were randomized. So this is all done by computers. You don't have any way of influencing it, but randomized 2 to 1, which meant for every 3 people, 2 received olaparib and 1 received placebo. And the treatment was given for 2 years. And the reason that they chose 2 years was the sort of greatest risk for the cancer coming back is within the first 2 years. And the theory was that the 2 years would cover that time period. And this was really one of the most positive trials we've ever seen, not just in gynae cancers, but in any cancer. The addition of olaparib to chemotherapy led to this huge improvement in outcome, unprecedented. It's not something we've seen in ovary cancer or other cancers. So there was at least a 3-year improvement in disease control. And I say at least because it hadn't reached the end by the time they published the data. There was a 70% reduction in the risk of recurrence. In general, the tablets was well tolerated. On the basis of this, widespread licensing was approved for olaparib for BRCA cancer. So we've had that on the Cancer Drugs Fund in England and equivalent in Scotland since July 2019. But as I said, this is only for BRCA mutation. So that's about 1 in 5, 1 in 4 ovarian cancer. So what about everybody else? Well, following on from this trial, or the following year, this data was presented, and this looked at niraparib in a very similar situation. Now, niraparib and olaparib are essentially the same drugs. They're made by different companies. They have slightly different side effect profile, but we all consider them to be equivalent in terms of efficacy. But they have slightly different, like I said, side effects and different ways of taking them. But essentially, it's the same drug. And in this trial, they gave niraparib. And again, it was a randomized placebo-controlled trial, newly diagnosed stage 3 or 4 after chemotherapy and surgery, included BRCA and non-BRCA. And we did HRD testing as part of the trial, but we didn't know the results before they went on the trial. And here, this was a bigger trial, 733 patients, some with a BRCA mutation, about 200, and then the rest without a BRCA mutation. And again, 6 cycles of chemotherapy, surgery where possible, although in this study, it wasn't mandated to have had surgery. And again, randomized 2 to every 1 to receive niraparib or placebo. And here they chose 3 years of treatment. And again, to cover the period that's the higher risk of recurrence, but also there were more patients in this study that hadn't had an operation and perhaps had slightly higher risk disease, which I think was the reason for choosing 3 years rather than 2. And again, what we found in this study that niraparib significantly improved outcomes for all patients, increased time free from cancer, reduction in the risk of recurrence. The benefit was the greatest for BRCA mutant or BRCA abnormal cancers, but also significant benefit was seen for the non-BRCA patients, including the HRD positive and then the HRD negative. So there was a benefit in the HRD negative patients, but it wasn't quite as high as in the other groups. And again, on this study, they showed no impact on the quality of life, and niraparib received approval in Europe and then in the NHS for all patients, regardless of BRCA or HRD status. And then the final trial to know about is the combination. So this was looking at the combination of olaparib with bevacizumab. And again, all these trials are very similar, randomized, placebo-controlled, newly diagnosed stage 3 or 4, after chemotherapy, and you could be in it whether you're BRCA or not. And again, about 200 odd BRCA patients, and then the rest without a BRCA mutation. And the difference with this trial was that everybody had to have received bevacizumab with chemotherapy. This trial was predominantly performed in Europe, where bevacizumab was the standard of care. So here again, randomized 2 to 1 to receive olaparib or placebo, but the difference was that everybody received bevacizumab, and they had no arm where you just got olaparib. So it was either olaparib and bevacizumab or placebo and bevacizumab. And again, what we found was adding olaparib to bevacizumab improved the outcome, increased time free from cancer, biggest benefit in the BRCA patients, but also significant benefit in the HRD positive patients. But interestingly, in this trial, there was no additional benefit of adding in olaparib to bevacizumab in patients whose tumors were HRD negative. And so on the basis of that, this combination was only improved for either BRCA or HRD cancer. So if I show you the pie chart I showed you before, that's this half or just over half on the right. So this combination is only available for HRD because adding olaparib to bevacizumab didn't seem to benefit the HRD negative cancers. So that's the trial data behind it. And on the basis of these trials, all the guidelines, and we use the European Society of Oncology guidelines, they recommend incorporating HRD testing with BRCA testing for all ladies with newly diagnosed advanced ovarian cancer to determine the best maintenance treatment, and also to give us an idea about the expected degree of benefit from PARP inhibitors. And here, this is just a summary of the treatment that are available depending on the biomarker status. So the biomarkers we look at, like I said, is BRCA mutation in about a quarter, then HRD positive, but BRCA negative will be about 20 to 30%, and then about 40 to 50% will be HRD negative. And you can see that for every group, if you go down, there's more than one option. And there are a number of things that we have to consider, not just the biomarker, when choosing the best option for each patient. So how do we choose? And there's not one right answer. So every single person is individual, and there'll be various factors that we need to take into consideration. But we think about things like, what is the disease characteristic? So has someone undergone an operation? Is the cancer being removed? Is there some cancer there? For example, there are some incidents when we might not be able to give bevacizumab if there's cancer on the surface of the bowel. We obviously need to think about the biomarker status, BRCA, HRD, and what's approved. That's less of an issue now because we have access to all of these treatments, but when they first came out, some were available in some parts of the UK and not others. What about the drug properties? Well, what we need to think about is obviously bevacizumab's intravenous, so it requires coming up to the hospital every 3 weeks. The other treatments are oral. Olaparib's given twice a day, niraparib's once a day, so there are things to consider when choosing one over the other. Drug interactions, if someone's on lots of medications for other health problems, we need to think about what may or may not interact. In general, olaparib reacts or interacts with more medication than niraparib does. Bevacizumab doesn't tend to interact with any other medication, but in terms of side effect profile, some therapies cause high blood pressure. That may be a problem if you've got pre-existing high blood pressure. So we have to consider comorbidities, i.e. other illnesses. And really, what do people want? You know, what's your preference? What's important to you? And think about things such as quality of life. So all these things we have to take into consideration when deciding on the best option. So there's no two individuals that are the same. And it really requires a sort of detailed discussion to opt for what's best for you. So that's a summary of what we have in the first line maintenance therapy. I'm just going to touch on the rarer types of cancer. So as I showed you this pie chart before, we've got this sort of quarter of patients that don't have high-grade serous, so mucinous, endometrioid, clear cell, transitional, and some other even rarer subtypes. Now, when we think about the maintenance therapies that I've talked about, most of those trials were done in high-grade serous, but all the PARP inhibitors in the combination are available or appropriate for high-grade endometrioid, so grade 3 endometrioid, clear cell ovary cancer, carcinosarcoma, providing the histology breakdown is correct, assuming they meet all the other criteria with regards to BRCA and HRD. Bevacizumab on its own is available for any stage 3 or 4 cancer, regardless of histological subtype or grade. So low-grade serous, mucinous, etc. And the low-grade cancers are not eligible, or it's not appropriate to give the PARP inhibitors. And then what about hormonal therapy? Well, we're increasingly using hormone therapy, or should I say anti-hormone therapy, in low-grade ovary cancer. So letrozole is a drug. It's commonly used in breast cancer, and it prevents estrogen production. So if you've had both ovaries removed or postmenopausal, you're not producing estrogen in the ovaries, but you will still produce some in liver and fat tissue when other hormones are converted into estrogen, and letrozole prevents this. Like I said, it's been used in breast cancer for years. And low-grade ovary cancer is often hormone receptor positive, i.e. estrogen in the blood may contribute to the cancer cell growth, so thereby preventing it may have an effect. So retrospective studies, so where people have gone back and looked at patients who've had letrozole or other hormone treatment, they find that it's beneficial. And actually in low-grade cancer, we're increasingly using this rather than chemotherapy. And studies are ongoing looking at this. How long to give it, we don't know. So it tends to be 5 years, but as I said, it's not been well shown in clinical trials. So it's slightly different, but it looks to be a chemotherapy sparing regime, but only in low-grade cancers, which is only about 5 to 7% of all ovary cancer. And then what about maintenance therapy for cancer that may have come back? Well, we define recurrent ovary cancer by what we call platinum sensitivity. So if the cancers come back more or greater or less than 6 months than previous chemotherapy. So if the cancer is what we call platinum sensitive, so responded to further carboplatin or cisplatin-based chemotherapy, we can use PARP inhibitors, olaparib, niraparib, and rucaparib, regardless of biomarker, but providing they've not had prior PARP inhibitors. So we can only use PARP inhibitors once. In platinum-resistant disease, bevacizumab can be used as a maintenance treatment, but only in Scotland, providing they haven't had bevacizumab before. However, we're hoping this may become available in England soon. It's just become off patent, so it's become much cheaper. So we're applying to get this back on the Cancer Drugs Fund for platinum-resistant disease, but PARP inhibitors are not appropriate in platinum-resistant disease. And then what about the future? Well, like I said, there was a number of trials looking at immunotherapy with PARP inhibitors and bevacizumab that have completed, and we should get the results of them later this year or next year, and that will determine whether there's any benefit of adding in immunotherapy to PARP and bevacizumab. And then there's a whole new class of drugs called antibody drug conjugates, and there's a lot of trials looking at these as maintenance therapy underway. And antibody drug conjugates are kind of like the new kids on the block, and we're leading the way in gynae cancers with this. So this sort of ugly thing here is an antibody, so like bevacizumab, and this antibody will bind to a specific thing on the cancer cell, and then you've got these linkers or bridges here, the green bits, that attach a chemotherapy molecule. And there are a number of different antibody drug conjugates listed here, but how this basically works is it's quite neat. So you've got the antibody in red, and then you've got these chemotherapy molecules sort of stuck on the side. And what happens is the antibody binds to something specific on the cancer cell, so something that's on the cancer cell and in theory not on normal cells. And it takes the whole molecule into the cell and breaks it down and releases the chemotherapy. So these are standard, often quite old chemotherapy drugs, but it releases them within the cell rather than going everywhere in the body. So it's targeted chemotherapy. You're delivering the chemotherapy directly to the cell. And these have shown some really nice results. Mirvetuximab, or it's also called Ella here, has just recently been licensed in the US, and we should have it here soon, for platinum resistance or recurrent ovary cancer that's resistant to platinum. But what you can see here is you've got this antibody which attacks something called the folate receptor on cancer cells, and it delivers chemotherapy into the cancer cells. And folate receptors present on about 50% of ovarian cancers. And in this trial, 450 patients were randomized to receive mirvetuximab, so that's this antibody drug conjugate, or normal chemotherapy. And what they found was that there was a significant improvement in disease control, tumor shrinkage, a longer survival. And like I said, this has just been approved in the US, and it's undergoing EU approval currently. So hopefully we'll have access to this soon. So this is a targeted chemotherapy in this situation of platinum-resistant disease. But actually there's another antibody drug conjugate. Again, this looks at something called HER2, which is very commonly overexpressed in breast cancer. So this is a drug we use often in breast cancer. But here they did a trial looking at lots of different cancers. And in the ovary patients, so that's these ones in dark green here, any line going up, that meant that with treatment the cancer grew. But you can see the majority of the lines, so each line represents an individual patient, that they're all going down in terms of reducing the cancer. And so this is another drug that we're looking at in ovary cancer. It's probably only relevant in about 10% of patients, but in the people that have this HER2 overexpression, it seems to work very well at early stages. So there are a number of trials looking at these drugs, these kind of new kids on the block, the ADCs, as maintenance treatment. So we're about to open a trial looking at TROP2, so that targets something called TROP2 on the cancer cells for HRD negative cancers. And then in recurrent disease, there's a whole host of trials coming through. So looking at the different ADCs and looking at giving it in combination with PARP inhibitors, and many, many more. So this is a real hot space for clinical trials just now. So in conclusion, it really is a great time to be involved with ovarian cancer research. And if I take you back to that slide I showed with the timelines, nothing happened for ages, and then suddenly there's been this explosion of new, really positive clinical trial data, leading to significant advances. And we're moving away from treating everyone as the same. So we've moved away from the one size fits all to this sort of personalized medicine, where we use genetics and biomarkers in the cancer to direct targeted therapy. And it really has significantly improved both options and outcomes for patients with ovarian cancer. So thank you very much for your time, and I'm really happy to take any questions.
And we're now going to move into the question and answer session. So to start us off, we received so many questions about the timeline for maintenance treatments. Rowan, perhaps you could kick us off by addressing our first question, which is how long can you stay on PARP inhibitors and what happens when you stop? This person in particular is interested in hearing about checkups. A lot of people mentioned a timeline of around 2 years, but it also seems like some people are expecting to be on them indefinitely. So yes, can you tell us about
Yes,
how long
of
people can
course.
expect to be
Yeah,
on?
that's a really good question. I get asked this a lot. So, the timelines depend a little bit on what treatment that you get. So, just to clarify, if you have olaparib on its own, which is for BRCA only, that's 2 years. Niraparib is 3 years, and the combination of olaparib and bevacizumab is 2 years of olaparib and 15 months of bevacizumab. And the time is based on how they did the original trials. And the rationale for having a sort of finite amount of time was because one covered the period which was the greatest risk of recurrence, and two, the drugs are not without their side effects. So it's about getting that balance right. However, in all those trials, if when you went onto the trial at the end of surgery or chemotherapy and surgery, if there was still some disease there, i.e. you still had evidence of disease, i.e. no evidence of disease or in remission, there was the option to continue on with the treatment beyond the 2 or 3 years. So, and that's how it's been approved by the Cancer Drugs Fund. So for anyone whose scans clear and their C125 is normal at the end of chemotherapy, then it's the set amount of time. But if you didn't have an operation or they couldn't remove all the cancer at the operation, you've still got cancer at the end of on scan at the end of chemotherapy, then there's an option to continue beyond the 2 or 3 years, providing there's evidence that you're still benefiting from it. So in most people we stop, but we've got the option to carry on and for people that meet that criteria.
Right. Yeah, a lot of people asked us if the 2-year rule might be due to funding.
No, it's not. It's not funding. It's how the drugs were approved and licensed. And actually, when the studies first came out, we all had a bit of hesitation of what's going to happen at the 2 years or the 3 years with niraparib. Will we see a spike in recurrences? But actually, that is definitely not the case. So, the trials are now 7-8 years. We've got follow up, and it seems to be that if you've completed your treatment and you're okay at the end of treatment, then you tend to be okay as time goes on as well.
Great, thank you. So that kind of leads me into the next question, which is what, if any, risks are associated with staying on a PARP inhibitor for that longer term period?
Well, we'd only carry on beyond the 2 or 3 years for people who still had evidence of cancer, and then you're balancing up the risks of cancer progression versus the toxicities. So firstly, in terms of the PARP inhibitors in general, they're well tolerated, but there's quite a lot of, or there can be some low-grade side effects with nausea, fatigue, funny tastes, feeling a little bit under par. And it's interesting that often when people stop, they suddenly they sort of report not having realized that they didn't feel 100% before, because remember, we start the PARPs after chemotherapy, so often you may still have side effects from chemo, and PARP inhibitors are not that bad, but often people feel a lot better when they stop. So that's one thing, is even though you may not realize it, it does have some effect on quality of life. In terms of more serious long-term consequences, the PARP inhibitors all have a risk about 1 in 500, 1 in 1,000 of something called myelodysplastic syndrome, or AML. So that's a blood disorder which can lead to leukemias, and the longer duration, the risk does increase with that. So that's another reason for stopping at the 2 or 3 years.
Great, thank you. And we've had another question about timeline, which is, do PARP inhibitors lose effectiveness over time? And that might be linked in with the next question, which is, why can you only use them once?
Okay, they're slightly different questions. So I think we use PARP inhibitors in different ways. So if you're having it when you've got no evidence of disease or you're in remission at the end of chemotherapy, then the reason we're doing it is to prevent the cancer recurring. So that's why it's a predefined set amount of time. If we give it for recurrent disease when there's cancer that is there, then we're giving it a slightly different way, and there is a chance that with time the cancer can become resistant to the PARP inhibitors, as with any drug. The reason that we can't give it twice is because there's not yet data to support it. So there are trials ongoing. There's a small trial which showed a potential benefit of giving it again, but I think that really depends on on the timeline. So if, say, someone has completed their 2 years of or 3 years of PARP and then the cancer comes back sometime later, it makes more sense to give the PARP again rather than if the cancer came back when on the PARP. So we can't do it because there's no data to support it. It doesn't mean there's no rationale for doing it, and we're looking at that just now. In fact, some of the trials I mentioned are looking at giving PARP again.
Right, thank you. So this kind of leads us into some questions that we've received about the possibility of cancer coming back, so recurring after PARP inhibitors are stopped. So one of our questioners has asked, am I correct in thinking that should I have another recurrence, I wouldn't be able to go back on olaparib after treatment? If not, what is the reason for this? I think maybe we've just covered that.
Yeah.
But another person's asked, is there a high chance that cancer can return after coming off the medication? And is there a most likely time period following all clear that that might happen?
So, like I said, there isn't a high chance of the cancer coming back when you stop the medication. So all the trials have borne that out, that there isn't like a sudden peak of recurrence when you stop the PARP inhibitors or the bevacizumab. There is a risk of the cancer coming back, but as time goes on, that gets less. So the greatest risk is within the first 2 years, which is why these treatments all cover that period of time.
Thank you. And we've also received a number of questions about the use of PARP inhibitors alongside other medications. So somebody's asked, is olaparib more effective if taken alongside Avastin, and in what particular situation would that be appropriate?
Yeah, so that is a very good question that we ask all the time. So if you remember the trial I showed you with the olaparib and bevacizumab, one of the big issues with that is it didn't have an olaparib only arm. So in the BRCA patients and the HRD, we don't know the added benefit of the bevacizumab to the olaparib. So we have to kind of consider various things. So if you're HRD positive, you can have olaparib, bev, or niraparib, and if you're BRCA, you can also have olaparib. And the decision to give the combination versus the monotherapy is really much based on each individual patient. So it might depend on, willingness to come up for IV treatment, other reasons not to give bevacizumab, for example. For us, for the BRCA patients, we tend to just give olaparib on its own unless there's other features that make us want to give bevacizumab that relate to when we would have given bevacizumab before. So for example, someone has had an operation or had some cancer left at the time of surgery, then we might consider the combination rather than one single. But there isn't any good data to show that the combination is better than the individual drugs. It's just the way the trials were done and they've been licensed.
Yeah. And we've had another question about the difference in effectiveness of different PARP inhibitors. So this person's asked about niraparib and olaparib with Avastin. So they've asked, is there any difference in the effectiveness of niraparib compared to olaparib with Avastin? And is this different in different groups of people, for example, people who are HRD positive?
So we don't know the honest answer is we don't know because we've not compared, because like I said, in the olaparib bev arm there wasn't a olaparib only. What we can say is that the PARP inhibitors are very similar. So there's not any difference between olaparib or niraparib, but just a bit on where they've been licensed. So olaparib, for example, is not more effective than niraparib on its own. And they seem to be very similar. So if you're HRD positive, the benefit of niraparib seems to be very similar to the combination of olaparib and bevacizumab, but nobody's done that trial to say exactly how much bev adds onto the PARP.
Thanks. So we're just going to move on to talking about side effects now. So we've had loads of interest in the topic of managing side effects. One of our attendees has asked, is there anything users can do themselves to help the body deal with side effects? And they've mentioned that they're referring to improving health rather than doing something like taking a blood pressure medication, for example.
Yeah, I think so. There are some side effects which, like a low blood count, which are drug related, that you can't, do something specific for. But in terms of managing fatigue, controlling blood pressure and energy levels, then sort of gentle exercise, eating a well diet, the kind of general healthy lifestyle things I think are all quite helpful. You can get, particularly when you start PARP inhibitors, fatigue, and some people it can be quite marked. And I think the way to manage that, I'm sure you do lots of workshops and things on managing fatigue, because it's a common problem, but as you know, gentle exercise and building things up is definitely the way forward. There isn't any sort of definite do's or don't with the PARP inhibitors. Niraparib and bevacizumab can both cause high blood pressure, occasionally dangerously high blood pressure. And if that's the case, we have to do something about it, either stop the medication or give some blood pressure medication. But most things can be done complementary to any intervention that we might have. And a lot of the side effects improve with time. So nausea, fatigue usually dissipate after the first month or improve after the first month of treatment.
Thank you. Yes, and as Rowan mentioned, we do have lots of information on our website in the support for you section, sessions like this, looking at things like fatigue, healthy eating, that kind of thing, if anyone's interested in finding out more about that. So now to a more specific side effect. Someone's asked, can kidney damage reverse when PARP use ceases?
Yeah, it's more common with rucaparib or olaparib, and it's to be honest, it's more an effect on the blood test rather than affecting the kidneys per se, and it reverses when we stop.
Great, thank you. And somebody else has asked, does PARP use make it harder to tolerate subsequent chemo?
That's yeah, that's a good question. I think on the trials that wasn't borne out, but I do think if someone has particularly sensitive bone marrow, so they often have problems with their counts and they've maybe struggled with the PARP inhibitors, there may be, I don't think in terms of tolerability, in terms of how they feel, but their blood counts may be a bit more impacted by subsequent chemotherapy, particularly if you've gone straight from PARP to chemotherapy. But that's the same as if you've had previous chemotherapy, it makes it harder for the next time as well. So it kind of has the same effect as chemotherapy.
Great. And we've also been asked, do the side effects of the different PARP inhibitors, are they similar or are they different? So olaparib versus niraparib.
Yeah, they are different, and that's one of the things we consider. You know, if we're choosing between the two, they are there's some similarities, fatigue, nausea, but there's some that are more specific to one than the other. So niraparib causes high blood pressure, olaparib doesn't. Niraparib can cause insomnia. Olaparib can affect the kidney. So if you had someone with kidney, whose kidneys weren't 100%, you might go for niraparib over olaparib. Olaparib interacts with more other medications. So if someone's on lots of medications for certain other conditions, then it may be that niraparib's a better option. So they're the things we would consider on an individual basis. They are there's overlapping, but some of them are quite unique to one or the other.
Thanks. So we're going to move on now to some questions that have come through about treatment options in different groups of people, so different people with different gene mutations, etc. So somebody's asked, maintenance treatments appear to be focused on those with BRCA mutation. What are the options for those who don't have that BRCA mutation?
Well, so BRCA is about 20%. All those combinations that we discussed are, so the combination of olaparib and bevacizumab is for HRD positive, but BRCA negative, well, and BRCA, but BRCA negative as well. And niraparib and bevacizumab as monotherapy are approved for all. So yes, the first trial was done with BRCA, but it's been extended to include all. So all those treatment options are, well, not all of them, but they're treatment options for all different groups.
Thank you. And we've also been asked, if your HRD testing is inconclusive, can you still access maintenance drugs? This person is specifically BRCA negative.
Yeah, so if it's inconclusive, which does happen a lot less now than it used to when the first test came out, you can still access niraparib, because that's available for regardless of HRD status, or bevacizumab on its own if you meet the other criteria. So, but you can't access the olaparib bev because that's only for HRD positive.
Thank you. And this is a question that came in actually from a few different people on the chat today. So we had a lot of people ask whether people with particular mutations might be expected to have a similar response to a PARP inhibitor as someone with a BRCA mutation. So the particular mutations that were brought up were BRIP1, P53, and Lynch syndrome.
So BRIP1, yes. So BRIP1, RAD51, PALB, they all work on the homologous recombination pathway. So they would all have you'd expect to have a similar response to PARP inhibitors. And P53 is present in nearly all high-grade serous. It's about 99% of patients. It doesn't affect responsiveness to PARP inhibitors. It's the most commonly mutated gene in cancer across all different cancers, and people have been trying for years to find drugs that target it, and has yet been unsuccessful, but there's work ongoing. So P53 won't affect response to PARP. And then Lynch syndrome, again, it doesn't seem to affect response to PARP per se, but Lynch syndrome cancers are much more sensitive to immunotherapy, because it's Lynch syndrome is another type of DNA repair, and that would more push you towards immunotherapy.
Thank you.
So it's a very rare subgroup of ovary cancer. It's only about 3% of Lynch syndrome.
Thanks. Right. So we've received some questions about whether maintenance treatments can be effective against types of cancer that aren't ovarian cancer. So the main area of interest is breast cancer, which can be linked. So somebody asked, does taking olaparib for an ovarian cancer diagnosis also reduce the risk of breast cancer developing, and vice versa?
Okay, so I don't really know the data on maintenance therapy and breast cancer, so that's the caveat. I haven't done breast cancer for a long time. But if you are taking a maintenance PARP inhibitor, particularly for a BRCA cancer, for ovary cancer, it probably does reduce the risk of a subsequent breast cancer, although we don't yet have a lot of good data to support that. We're kind of looking at that now. But even just having chemotherapy for ovary cancer probably reduces the risk of breast cancer. And I would imagine the same is true if you've had PARP inhibitor for breast cancer, it slightly reduces the risk of ovary cancer. So that's what we all think, but we haven't got a lot of data to say that's definitely the case.
Thanks. And then a similar question related to Avastin. So somebody's asked, how effective is Avastin against other cancers that may occur, or is it specifically only for ovarian cancer?
So Avastin is not really preventative against other cancers, because Avastin is kind of an adjunct with chemotherapy, the preceding chemotherapy. It is used in some other cancers, but I'm not entirely up to date. I mean, I know they use it sometimes in colorectal cancer and brain tumors, so it is used with other cancers. It's not unique to ovary cancer, but it's not really it's not a preventative treatment, just by the way it works.
Thank you. And now to finish up, we have had a couple of questions on the future of maintenance treatments and how to access clinical trials. I think you actually might have covered some of this in your final few slides, but somebody's asked, are there any new maintenance treatments in the pipeline now, particularly for people who may have already been treated with a PARP inhibitor?
Yeah, so we're really looking at that, and there's a kind of a whole explosion of trials coming through in the pipeline looking at maintenance treatment for people who've had PARP before. So some of those drugs I talked about, the antibody drug conjugate, so the sort of targeted chemotherapy, and some with PARP inhibitor combinations or drugs that work similarly to PARP, like ATR inhibitors. So there are some ongoing and about to start. So what I would recommend, if it was something that was interested, is that you speak to your oncologist, and they can always refer you into somewhere if the trials are not running at your hospital. But there are a lot of studies looking at exactly that, both here and worldwide.
Thank you. And that perfectly leads me into the final question. So somebody's asked, can you access clinical trials without going through your oncologist? And if so, how do you do so?
Yeah, you can. I mean, normally if people are referred, if it's for a specific trial, we normally ask for a referral letter from your oncologist, but I mean, your GP can send that too, but we would need information about previous cancer history and access to, tumor biopsies and things like that. So it is possible. Sometimes people self-refer, but we do need the previous information. So there's information, I think, on your website and some of the other websites about all the trials that are running, so you can access them. And if you think it's appropriate, I would suggest speaking to your oncologist first, but it is possible to do it without, if there's whatever reason you can't.
Yeah. So we've got a section on our website, targetovariancancer.org.uk, where you can search just specifically for ovarian cancer trials. It's slightly different to some of the other databases that exist because it's specific to ovarian cancer, so you don't have thousands of other trials that you need to wade through. And yes, that can give you the information. As Rowan said, we'd always recommend going to your oncologist first if you can. That's the best way to access them. But again, if you've got any questions about that, you can call our support line and they'll talk you through that. Sorry,
what
Rowan.
I would say is sorry to interrupt, is that the gynae oncology world is a small community, and we do meet twice a year. And you know, there's hundreds, well, not hundreds, but you know, most of the oncologists attend that, and we go through all the trials that are running and where they're running. So we are very collaborative amongst different hospitals, and when the trials come to the UK, they do try and spread them out throughout the country so that everybody has access to them. But you know, most of us do know what's going on.
Great, thank you. So I think that kind of brings us to the end of the questions that we have time to ask today. Just one last thing, Rowan. What's the one thing that you would like everybody to take away from this Q&A, this session today?
Well, I think two things. One is things have really changed dramatically over the last few years, so it's really exciting time to be involved in ovarian cancer, and it's great to have options. You know, if I'd been giving this talk 3 years ago, I'd have had nothing to say, and now we've got all these questions about which option's best, because there's options, and you know, the more options, the better things are for patients. And secondly, you know, there's this whole vast a number of trials and new drugs on the horizon that are likely, you know, if I give this talk in 5 years' time, then we'll have many more things to talk about. So it's really a fun time to be doing ovarian cancer research, because there's lots happening, and it's great for patients because we've got so many more options, which have really made a meaningful improvement in outcomes.
Thank you so much. So we're going to end the Q&A session now. Thank you, Rowan, so much for spending time with us. I know we've gone through tons of technical information, statistics. So if you've got any questions or concerns, or would just like to have a chat, our support line is available. The number should be in the chat, but that's 02079235475. I'm sure you'll all join me in saying a massive thank you to Rowan for sharing her expertise with us today. Thank you to all of you for joining us. We hope you enjoyed it and found it informative. So on behalf of the Target Ovarian Cancer team, thank you again for your time today, and we hope to see you again soon at our next session. And goodbye.